I'm going to talk about the treatment of HPV-positive head and neck cancer, and we're going to discuss, as we go through, the biologic principles, the changing paradigms, and the new therapies for this 2020. First, some of my disclosures. I do some consulting, and I'm on data safety monitoring committees for Merck and Celsi, and I also have patents in antiviral and antibacterial human monoclonal antibodies. So HPV has been a disease that was really identified in around 2000 by a seminal paper from Johns Hopkins, led by Maura Gillison and Bill Westra, who is here. Since that paper, it's now been seen as an epidemic of cancer caused by a virus. And what we're going to be seeing is up to 30,000 cases of HPV-related oropharynx cancer in 2025. This was originally defined as a population of essentially non-smokers and young people, but what we're seeing now as everything matures, as people mature and this disease matures, that about half of smokers with oropharynx cancer will have HPV as a cause, and there's an increasing age that we're seeing, so it's not unusual to have an 80-year-old or 85-year-old show up in the clinic with an HPV-positive tonsil or base of tongue cancer. There are vaccines that are effective for prevention. There are no therapeutic vaccines at the moment. And the vaccines that we have will take about 30 years to impact the cancer rate, although they will reduce the rate of HPV-related genital warts and HPV-CIN in cervical cancer. What's notable about HPV oropharynx cancer is that its prognosis is excellent, even in advanced disease, and up to 80% of patients will be alive at 5 years. And all of the modalities that we have are highly effective in treating this cancer. This has led us to know and understand that in the next 30 years, we're going to be seeing people who are 10, 20, 30 years past treatment and are now having considerable late consequences of treatment. So one of our aims is to preserve survival in this patient population, but reduce the morbidity and mortality of treatment. Of course, one of the ways to do that will be to prevent the cancer, and I'll get into that in a moment. HPV is a DNA virus. Corona is an RNA virus. As a DNA virus, it tends to have a much more stable genome. It has essentially six early antigens, which are involved in viral management, assembly, and usurpation of the cell, and two coat proteins, L1 and L2, which are late and are used to wrap the viral DNA and help it export and then enter cells. As a circular virus, it can integrate into the genome, and one of the modes of potentially making a more aggressive disease is when it does integrate, and its integration sites in the human genome are essentially unknown. They're variable, and there's no specific site that seems to be more attached by these. There is a difference in that oropharynx cancer, as opposed to, say, cervical cancer, has much more in the way of episomal disease, while cervical cancer is much more integrated virus. There are well over 200 types of HPV, but only about 30 mucosal types that are high risk for cancer. HPV causes about almost 100% of cervical cancer and anal cancer. It also has an impact on vulvar vaginal cancer and penile cancer, and it causes about 75% of the oropharynx cancer that we see in the United States. Also, an increasing recognition that nasal cavity cancers are also caused by HPV. And the distribution of HPV types is different in these different cancers. Cervical cancer is about 50% HPV-16 positive, 40%, and a substantial amount of HPV-18. And then other types, anal is primarily 16, vulvar and vaginal appear to be primarily 16, as is oropharynx, and nasal cavity is a mix, just as cervical cancer is, for reasons that we don't understand. The virus itself is a very small non-virus. The peptides are relatively small, and they are not enzymatic. They basically bind to other proteins and either modify their function or disable them. The principal targets for E6 and E7, which are the primary carcinogenic drivers, are RB, which is inactivated by E7, and P53, which is inactivated by E6. With these two drivers of keeping apoptosis from and apoptosis and preserving the cancer process and driving the mitosis and growth of the cancer cells through RB, E6 and E7 are actually quite necessary for preserving the malignant state in the tumor cells. And so inactivation of E6 or E7, if that were feasible, would actually help to treat the cancer. Currently, these are not enzymatic targets, and so there's really no inhibitor that has been identified for them. So the principal areas of clinical research for HPV oropharynx cancer are in prevention, screening, primary cure, and then treatment of recurrent and metastatic disease. And I'm going to go over these in sequence. First, this is the HPV vaccine. Through molecular technology, empty viral particles have been produced expressing the L1 protein. They self-assemble, and they've been used to vaccinate people, and they result in prevention of CIN, and also for those that are the low-risk HPV 6 and 11, which cause genital warts, they block and prevent genital warts in young adults and adults. We do not know the mechanism of protection. Although antibodies are elicited, we don't know if they block viral entry, if they enhance phagocytosis, or if they simply lock in the DNA and the virus by cross-linking the viral shell. So there was a shot in the dark, an a priori decision that if you give a shell, you'll produce antibodies, and antibodies will protect against infection. And that works for hepatitis B, it works for HPV, and hopefully it'll work for corona, although we don't have any real clue yet as to how that might work. The optimal schedule is really unknown. It was chosen to give individuals 3 injections. The reason that this works, even though we get infected with this virus, is that the immune response, both antibody and T-cell mediated to HPV, is muted, particularly in the cervix, and for reasons that we don't understand, we don't produce robust antibodies in response to infection. And just about everybody is infected by the time they hit their 20s. There are 3 vaccines that are available: Cerevix, which is HPV 16 and 18, Gardasil, which includes the genital warts, and Gardasil 19, which is a recognition that fully half of the cases of cervical cancer are caused by non-HPV 16 types, and you see here a list of the various types that are included. The vaccine has been approved for children, and now recently for adults through the age of 45. So I urge you that if you're able to get this and you're under 45, that you actually get the vaccine. It's effective in eliminating warts and HPV-CIN in women, so these are established evidence of efficacy. We have here at Mount Sinai a very vigorous vaccination program in East Harlem and Central Harlem for young women, and it has been very effective in eliminating CIN for them. We actually have, through Angela Diaz in the pediatric group, a higher rate of vaccination than in the Upper East Side. So I think it's a testimony to the efficacy of the vaccine and to some of the efforts and ongoing research that are going on here at Mount Sinai. Here is a trial for screening that is being run through our ENT partners. Brett Miles is the principal investigator. This is the mouth study, and it's accruing men and women between 35 and 75, women who are partners of partners of women with cervical dysplasia, partners of patients with HPV OPC, and then people with 3 or more lifetime oral sexual partners, which appears to enhance risk. There are a couple of other minor requirements, and the study consists of a survey of behaviors, which is completely anonymous, saline and oral swish to see if we can collect virus from a wash, a sample of saliva, urine, and blood. And the blood is being tested for cell-free DNA, which I'll explain later in the talk. A head and neck exam is performed, and if a person is found to be positive on any of the screening assays, they then come back for additional testing and for further follow-up on a yearly basis. So it's an excellent study. I am patient number 3, and there are several other people in our group that are in there as well. And I can tell you that I was not called back for screening, although I have taken care of people who have been called back for screening. So far, we've not identified any cancers, and I will point out that this will not only identify oropharynx cancers, but the blood test may well identify anal and cervical cancer in subjects. We know from the cell-free DNA studies that anal and cervical cancer patients can be identified from cell-free DNA as well. This is a survival curve from a large phase 3 trial we completed in 2000 or reported in 2011, looking at the oropharynx cases, and we were able to do HPV testing, which was not available uniformly at that time, and identified the HPV positive and HPV negative oropharynx cases. And here you see the tremendous difference in overall survival at 5 years in HPV positive patients versus HPV negative patients. Literally 80% of patients alive versus 35% in the HPV negative population. And this was incredibly significant. And it goes towards how responsive these cancers are. It's not that they're less aggressive, it's simply that they're more responsive to our therapies. Now, given that we know we can cure these patients in a variety of circumstances, a number of studies have been done to de-escalate a treatment. This is a study performed by RTOG, and also there'll be another study which I'll show you performed in England, in which the notion that one could give essentially the same dose of radiation that's used to cure this cancer, 70 gray, with cetuximab rather than cisplatin as a de-escalation. This study uses a altered fractionation technique, which adds additional radiation visits in the last 2 weeks and shortens the course to a 6-week program. I think this was a terribly flawed study. The notion that you could reduce toxicity by adding cetuximab rather than platinum is not borne out by our understanding of toxicity in these patients. And there's really no good support for this, but there is a philosophy and agenda within the radiation oncology community that giving chemotherapy as opposed to cetuximab, which is simply a different form of chemotherapy, is bad, and giving biotherapy, as cetuximab was called, is good. And so this trial was performed. And what this trial demonstrated was, in this actually good prognosis population, that you absolutely need cisplatin. Cetuximab does provide some radiation sensitization, but the cure rate in the cisplatin population was significantly better. And the progression-free survival in the bottom right-hand corner, you can see, was also significantly better. This is local regional failure, which is what you would expect from cisplatin, and you can see that it was almost twice as effective in controlling the local regional disease as cetuximab, and this was highly significant. This study was reported in the Lancet last year. The de-escalate trial by Mahana and his group in England attempted to prove the same using cetuximab with a more standard fractionation radiation schema, which is what we are using generally here, and they also showed the same thing. An overall survival advantage that was significant for the cisplatin group, with the hazard ratio misidentifies actually the degree with which cisplatin enhances the cure. Its absolute value is around 8%, but it's 6 times less likely to die, which is one of the ways in which one has to look at hazard ratios. Now, this is a study that was performed by the NRG, again, an RTOG trial, HN002, and this was published as an abstract at ASTRO, so we don't have all of the information to evaluate, but this evaluated 6,000 centigrade over 6 weeks with weekly cisplatin versus an altered fractionation scheme without chemotherapy. The patients were randomized. They were relatively low-risk patients with no smoking in their history of less than 10 pack years, which proves to be a very important finding. And this is a phase 2 trial, so it's not a randomized phase 3 trial against a standard of care. And what this identified was that the cisplatin resulted in a highly significant rejection of the null hypothesis, which is that it didn't achieve a certain level of efficacy, while the altered fractionation regimen failed to hit that hypothesis. And here's another example of the data. Here's a 3 times greater risk of local regional failure when you give IMRT in this setting without cisplatin. Now, I want to emphasize that these are fairly low-risk patients, and without smoking, they probably don't even need much in the way of additional treatment beyond the chemo-RT they received. And you can see that it was a highly significant improvement in survival by adding platinum. So I think what we see here is that cisplatin is essentially necessary with the chemotherapy as a sensitizer. It's simply the best one there is so far, and just giving the radiation alone is not going to be a good option if we're trying to dose reduce, and we think about what the causes are of toxicity in patients who receive radiation. This is ECOG 1308, which was published in 2017. And in this study, patients were treated with, this is a phase 2 trial, so they were studied with induction chemotherapy. They had relatively advanced disease. There was no smoking elimination for these patients. They were allowed to be smokers, and we'll see how that played out. Once they achieved their chemotherapy program, they were assessed for response, and clinical complete responders went on to receive chemotherapy with cetuximab and IMRT with 54 centigrade, and non-responders received almost 7,000 with cetuximab also. This study, of course, would have benefited from putting cisplatin or carboplatin into the radiation, but didn't have the option of that data at the time. The PFS and survival based on dose shows that the patients who responded survived better on the lower dose, and then the overall survival on the lower dose was 93%, and progression-free survival was 80% versus a relatively reduced survival and progression-free survival. Notice the survival statistics are very good in these patients. It takes a long time for them to progress beyond the initial progression event if they're treated. They're very responsive to therapy, and sometimes they can be salvaged with local surgery. Here is a list of the failures on the low dose group, and I want to point out that these patients are primarily smokers. This patient is the only one who never smoked who actually had a recurrence. This patient died from a boating accident and didn't recur. So the progression event was a drowning. But here you see the significant issues were smoking, T4 size, and N2C. N2C is bilateral nodal disease or contralateral nodal disease. There was no assessment for extracapsular extension, which can be assessed radiologically. So extracapsular extension, which is invasion of the soft tissues outside of lymph nodes in the neck, is a negative prognostic feature which shows up in other studies, but was not evaluated in this study. So if you had those poor prognostic features, if you just look at smoking alone reduced survival substantially in this population, and also progression-free survival. And if you looked at the N2B patients by smoking history, the same showed up. 1-year progression-free survival was somewhat lower. Here is a trial that we performed here, which we called the quarterback trial, where we reduced radiation therapy from 7,000 to 5,600 centigrade. Patients received 3 cycles of Taxotere, cisplatin, and 5-FU with a reduced dose of 5-FU. They were assessed for response, and clinical responders, not complete responders, but clinical responders, were then randomized to the low dose or the standard dose treatment with carboplatin as the radiation sensitizer. The important factor here was that we eliminated patients with greater than 20 pack year history. The writing was on the wall years ago when we did this study that was a major risk factor, and we included anybody who was high risk HPV positive, and We were looking at 3-year local control, progression-free survival, and ultimately overall survival in this patient population. This is combined data from that trial as well as the follow-up phase 2 trial in which we just treated patients with induction chemo and chemo-RT. And what we had in the original study here, and I haven't got all the data for the other one because we're just following up, with greater than 5 years survival, we had almost a 90% survival in standard care, standard patients, and 83% in non-standard. All of the failures were early, as you can see here. And what's important is that we had T4 patients, N2C and N3s, extracapsular extension radiographically, and we had other high-risk HPV types in this population. We actually had 4 patients with non-HPV 16 types, and of those 4, 50% failed. So of the 3 patients that failed in the 20 that were in this study, 2 were not HPV 16. So we had a very high HPV 16 control rate. When we look at the combined data, our progression-free survival is 84%, local regional control is 88%, and distant metastases rate, we had 1 patient out of those 32 who had a distant metastases. So we beat a lot of the other studies that are out there in terms of distant metastases, local regional control, and overall progression-free survival. We have, of the 5 patients who relapsed, all of them did so within 4 months of completing their initial treatment, and 1 of them is still alive on immunotherapies. So our overall survival is actually very close to, is 88%. So it's a pretty remarkable result. We are continuing this trial with a slightly reduced dose of 5-FU, and we're in the process of taking a look at the data. Just so you know, the combined phase 2 patients, the patients who were on the follow-up trial, there are 20 of them, and they're all more than a year out from the start of therapy and more than 6 months out from completing their treatment. So we don't expect any relapses in this population. Here is the SIRS trial, which is the Sinai robotic surgery trial. This is taking advantage of the really excellent surgical teams that we have here. And this is led by Dr. Miles and Dr. Jendon, and from that group. Patients are consented before they get their surgery, and they're consented on the basis of their scans and meeting the criteria, which are high-risk HPV positive and P16 positive, but P16 positive is all that was required to do the surgery, since we didn't always get the HPV status until the patient either had surgery or when they were about to get surgery. They had to have less than 3 nodes, no extracapsular extension, matted nodes, which is a sign of extracapsular extension, N3s, or nodes that were low below supraclavicular nodes, or in what we call level 3. We also did not allow T4s on this, and non-smokers, less than 20 pack years, and no active smoking, which meant the equivalent of 1 cigarette per day anytime during the last 5 years. These were very stringent, but we knew that smoking was a bad prognostic feature. We knew that we weren't going to operate on T4 patients and leave a positive margin. And leave a negative margin, and we knew that the risk of distant metastases was higher with ECS and matted nodes. And so these were 3 groups that we had, and you can see what the criteria are with decreasing levels of pathologically determined poor prognostic features. We actually just did surveillance in this group of patients. We did radiation in these, and we've recently broken this group out to give less radiation to people with nodes that weren't didn't have extracapsular extension or no surgical margin. And even here, we're substantially less than the 6,600 that would be given as a post-operative course with chemotherapy. And you can see that these are reduced dose radiation treatments. This is the overall results for the first 50 or so patients that were included in the trial, 54. And the data over here is the detailed data. We had 4 local regional failures. All of them were salvaged and are more than 10 months out. Some are 2 years out from the salvage treatment. The progression-free survival is 91% because we had 1 cardiac arrest. And the disease-specific survival, that is disease-caused death, is 100% survival. The overall survival is 98%. And here you can see that we had 2 failures. in group 1 out of 25 patients. We had 1 fail in group 2 and 1 in group 3. So these are excellent data, and the overall survival is great. One of the reasons that we did this study, so you understand, is we feel and felt that if we had such a high cure rate with radiation alone and we weren't impacting on the genetics of the trial by doing surgery and perturbing the cancer cells in a genotoxic way with chemotherapy, that we could salvage patients and give them radiation if they failed. Why subject 50% of these patients, in this case it would be 93% of these patients, to radiation that they ultimately wouldn't need? And so this was truly a complete de-escalation from radiation in that population. So this was presented recently, and hopefully will be coming out in a manuscript soon. This is a trial that was performed and is being performed by ECOG, the Alliance. It is a surgical trial also, patients with reasonably modest disease were treated with a transoral resection. This doesn't just use TORs, there's also micro laser dissections, MLD, which is also used. So they allowed people to have an approach that would allow a transoral resection as opposed to the older form of dissection, which required a jaw split or going in through the neck, which caused a lot of collateral damage and consequences. So patients who had low risk disease went to observation, and patients who had intermediate risk disease got reduced dose radiation, were randomized to reduced dose radiation or a higher dose of radiation. This was a 2-year progression-free survival. Those patients with very high-risk features, that is positive margins, extracapsular extension, or greater than 5 metastatic lymph nodes, 5 or more, were given a standard dose of radiation and cisplatin. So this was a really a big de-escalation in terms of dose of radiation, as we've done, but also in reducing, in giving more radiation, but no chemotherapy at that point. This trial was going to be reported, we thought, at ASCO this year, and hopefully we'll see it in about 3 weeks, 4 weeks when ASCO data is released. This is a trial that is being started by the NRG, and this is an attempt to do a randomized, large-scale phase 2 trial. This is a massive trial, which will not answer any question whatsoever. There will be no phase 3 answer by these patients put on this study. They're going to get standard treatment as a control arm. The experimental arm is 6,000 centigrade plus 100. This is not what was done in HN 002. It's entirely different. For some reason, they didn't feel they wanted to use the phase 2 data that they had. And then they have an experimental arm, which is Nivo plus a reduced dose of radiation. And I will point out that there's no evidence that this works. There's no good phase 2 data. There's no randomized data. And lots of drug companies are doing this kind of study. So why HN 005 is doing this instead of establishing a reduced dose standard of care for patients, I really don't understand. They did say that they would go to a phase 3 extension trial and randomize to the control arm versus the best experimental arm, or maybe both of them if it turns out to be the case. But the point I want to make here again is that this is a very reduced risk group of patients. These are patients that, you know, some of whom we wouldn't give any radiation to at all. And so here, the notion that they're going to have a big difference in the curves that will pick one of these arms is very limited, and they're going to spend 5 years and 1,000 patients to get a nothing burger, which I think is really sad. This is what's going on here. The principal cause of radiation toxicity is radiation dose and field. We can impact by the chemotherapy agent. We can make it worse with cetuximab or Taxotere, or we can keep it modest with cisplatin or carbo. There are underlying comorbidities that also impact on the amount of radiation and dose and field that lead to patients not being able to be treated optimally. So if we're going to reduce toxicity, we really have to reduce radiation in any of these 3 areas. De-escalation therapy strategies we can use surgery to identify high risk. We can reduce radiation by reducing field size or the total dose, or using protons, which are available and will reduce the field size dramatically. We can use chemotherapy with radiation or sequentially. We can use chemotherapy to reduce all the radiation. We can use it to improve poor prognosis patients, and we can do it for good prognosis patients as well. So it's very reasonable to look at these as de-escalation strategies. I don't think altered fractionation with the same dose is a de-escalation strategy. There's been no evidence that it improves outcome in any population compared to chemoradiotherapy. De-escalation therapy decisions are nuanced. So the important factors that we have to look at are smoking history, extracapsular extension, T4, contralateral nodes, matted nodes, non-HPV 16 high-risk types, which we are not entirely clear about yet, low nodes, which bespeak systemic spread, multiple nodes, same, N3 nodes, same, positive margins, and operability. You're not going to do a TORS procedure in somebody you know you're going to leave a positive margin. You're simply kicking the can about what's going to happen to the patient down the road and engendering more toxicity. So patients for some of these have to be operable. So once again, the principal cause of radiation toxicity is radiation. There's been no reduced dose radiation dose phase 3 trial with cisplatin in the US. And until there is a definitive phase 3 dose trial, we can't take it as a standard of care. And there are innumerable trials in phase 2 showing that it's feasible, reasonable, and effective to have reduced dose radiation. And we just don't have that trial by the NRG, the NCI, or CTEP. These are the 3 responsible organizations that sit on the committees that decide what trials are going to be done. So we just have to, as a community, bring this to their attention. In our attempt to address this issue and treat our patients with reduced dose therapy, recognizing that that is effective, we have started a trial called risk-based dosing for HPV, or risk-based de-intensification. Michael Wattman, an intern at Sinai, has put together this trial. And what we're doing is we're taking patients who are not eligible for SIRS or won't be on quarterback, and we're putting them into this so we can give them a lower dose of radiation. And here we have a risk group 1, which is low risk, who are getting 5,000 with cisplatin. An increased risk here, again, non-smokers getting 5,400 centigrade. And here, risk group 3, 6,000 with cisplatin, and this is 20 to 40 pack year patients. They have non-HPV 16 types. They can be hypopharynx or base of tongue or larynx, inoperable, and they can have more advanced local disease. And then for the highest risk group, we're taking patients who have T4 N2C greater than 3 nodes or matted nodes, and they're getting induction followed by a reduced dose radiation, but not as reduced as the non-smokers are getting. So we're giving them 6,000 with carboplatin. So new targets and therapies in HPV. Immunotherapy looks very effective in about 30% of high CPS score patients, whether they're HPV positive or HPV negative. Checkpoint blockade inhibitors are really not the whole story. There's something else going on here. We just don't know the biology. There are multiple vaccines available, and a biomarker has now been identified. Cell-free DNA, HPV DNA circulates. The virus does not circulate in the bloodstream. The virus is not present in people's blood, but the viral DNA from necrotic cells and from cells that are destroyed and get into the DNA gets in the bloodstream is identifiable. And the high-risk serotypes other than HPV 16 may also be a biomarker for either different therapy or specifically more therapy. This is a study that was just published by Dr. Chera and the JCO looking at the availability of cell-free DNA and its potential for identifying patients with recurrent disease. Using a 1 positive test, they had 28 of these 115 patients positive for cell-free DNA after definitive therapy. None of these patients relapsed. When they had 2 positive tests, and I did a second testing in all of these, they had 16 patients. Of these, at the time of the paper, 15 had relapsed. giving you a very high positive predictive score for this, and a very, very good negative predictive value, 100%. So this is very good at relieving somebody's anxiety, and it might be better even than a PET scan for, or a CT scan for identifying new disease. 35% of the failures were local regional, which helps us to know that we can identify small volume local regional disease as well as higher volume potentially distant metastases. And here you see the local regional control and the data distant metastasis-free survival. You can see how this was impacted as well. So this is a really looks like a really robust test. There are other people that have tests like this. They're generally academics. Johns Hopkins have one. I'll show you a study we're doing with them. And the Dana-Farber has one. We've been unable to get one of these studies done here simply because we don't have the instrumentation available for it. We are working towards that, but there is now a commercial test available which funded this particular trial by a company called Novartis. So we will be using that in the future and doing research with it. There are therapeutic HPV vaccines that have been identified and are working. Most are directed to HPV 16 or 16 and 18. There is a T-cell receptor vaccine taking place at NCI with gene-modified T-cells, looking at T-cell epitopes. And also the T-cell receptor is the target for all of the vaccines under any circumstances, looking for epitopes that can be used by the T-cell receptor for targeting. There are ongoing trials at Mount Sinai with HUCAPA, Johns Hopkins, and the NCI T-cell trial is available for patients if they have HPV 16. This is the HUCAPA virus used for the vaccine. They take a arenavirus and they have modified it. It's LCMV, lymphochoriomeningitis virus, that was given to people experimentally in the 70s with no impact. So there were already phase 1 trials with this back in the wild 70s when the IRBs would have stopped this. It is taken up by dendritic cells. It releases the genetics, the DNA from the E6 and E7 that's been inserted into the virus, and then activates T cells and produces antibodies to those targets. It works well in mice who have HPV positive cancer, 16 positive cancers, and we are now engaged in a phase 1 study with this, and we have one patient actually who has stable disease after about 4 months of treatment, having had rapidly progressive disease up to that point. We are also doing a window of opportunity trial with the HUCAPA product. This is in development. The idea will be to intravenously or intratumorally inject patients prior to definitive therapy. We're going to follow both the immunity and any changes in the tumor. And these patients will get a post-treatment biopsy and then go on to either definitive radiation or go to surgery and have their tumor looked at for immune responses. We plan to put about 20 patients on this, and it'll take anybody who is HPV 16 positive who doesn't fall into our other trials. This is a biomarker adjuvant trial that we're doing with Johns Hopkins. This is a trial in which we're taking newly diagnosed patients who are getting treated. They're going to get standard therapy. We'll obtain blood from these patients as well as the oral rinse, serum, and plasma. They'll be monitored using the Hopkins study. It's designed test for cell-free DNA. And if they pop up positive, those patients who are positive will get Durvo. Those who are, or will be randomized to Durvo or a vaccine plus Durvo, and arm A will be the control arm, because we do not want to randomize patients who we know are going to relapse to simple observation. We're going to retest those patients, and if they don't have clearance of the HPV DNA, if they get a second positive test, they will go on to Durvo and the vaccine, and we'll consider that a failure in the observation arm. So this was a trial designed to best treat patients who we know are going to have a problem from their disease. This is the vaccine. It's INO 3112. This is a plasmid that is actually 3 plasmids in the vaccine, one for HPV-16, one for HPV-18, and one for interleukin-12, which is a adjuvant that will enhance the immune response. Plasmids don't get taken up readily by tissues. This is going to be injected intradermally, and then something called electroporation, which is pulsing with electrical current that will open up the cells so the plasmids can enter and then become unsheathed and act within the cells. So this is a standard vaccine technique. It's been used in some of the HIV vaccines and in other vaccines for plasmid and naked DNA intradermally. So this is an ongoing trial that's open at Johns Hopkins, and we're trying to get it through our IRB. We were Corona interrupted, but hopefully we'll get this going in a few months. So I want to leave you with this. We have multiple translational research opportunities in prevention, screening, and treatment. There are multiple laboratories that have resources that can be turned toward HPV testing, both in virology and immunology, as well as in cancer mechanisms. There are active programs across Mount Sinai. I didn't mention Keith Siegel, who's doing an anal screening, anal cancer screening in HIV positive men and HIV negative, as well as women. There's a cervical cancer group through the Women's Cancer Group with Stephanie Blank. So we have numerous groups, and we have interest in cancer immunology and cancer mechanisms, and we have an infectious disease group here who are also working on their own vaccine for HPV that we'd love to get access to when they get to the point of putting into patients. So we have a lot of research going on here, and there are lots of opportunities. It's a big field, and there's a lot to be done. So thank you. Any questions?
Yeah, Marshall, it's Fred.
Hi, Fred.
I have a couple of questions. First of all, thank you very much for a very nice presentation. You mentioned smoking is a poor prognostic factor. Can you hear me?
Yes.
Yeah. Is that due to comorbidity, or is it any biological reason around it? Have you disclosed that? That is my...
The answer to that question is yes. It is due to comorbidities and to biological differences in the cancer. We don't know what they are. The comorbidity answer is very clear, that many of these patients may succumb from heart disease and vascular problems, second malignancies. That's not going to stop because they generally have high smoking rates. So that's why it's a risk factor for survival. But for disease specific, it may not be. So we won't know that until we actually do these reduced dose therapies and also look at them. But I think you can see in this study from ECOG, there was clearly an increased risk of recurrence, regardless of cause of death, in the smoking population. So I think both factors are active. Whether P53 is inactivated or there are other subsequent mutations that play on in TERT or in some of the kinases, I don't know, and nobody's really been able to identify. So,
right. Now I was thinking of P53 too. My other question, Marshall, is the treatment of advanced disease. Cetuximab seems to be included in trials, but not particularly effective. My question around cetuximab is, I don't hear about selection, biomarker selection, and we have had the same problem in lung cancer. EGFR antibodies hasn't panned out in unselected patients. We have demonstrated with cetuximab as well as with necitumumab that if you apply high copy number or gene amplification, you have reduced hazard ratio significantly in our last SWOG study, we demonstrated a hazard ratio of 0.32 in FISH-positive patients with cetuximab.
That's fabulous.
And we are in the process of publishing this these days, but just for your
So there's been a lot of exploration of EGF genetic abnormalities in head and neck cancer, and there is one small deletion mutant that has constitutive EGFR activity, but it does not seem to have any impact on cetuximab effectiveness. We don't have a high copy number. We don't have other mutations in the disease. The reason why 12% of all head and neck cancer patients respond to cetuximab is unknown, and we don't have RAS mutations to explain it in the cancer itself. So it's a very unique situation. There were a couple of things that people looked at in the past, but nothing has shown to be effective as a biomarker here. The best biomarker we've had, unfortunately, is rash, which is after you give the drug, and it's not that effective. We are doing a trial with cetuximab and monalizumab, an NK activator, which looks very promising, but we don't have anything for cetuximab directly. I will say this, however: no patient with head and neck cancer should die without having cetuximab as part of their treatment for recurrent and metastatic disease. It is active. It does cause stabilization, and it's worth doing. There are long-term survivors. I have people who are 2 or 3 years out on cetuximab alone. They're not a large number, but they're there.
Thank you.
Hi.
Hi, it's Ramon here. Very nice presentation. I just wanted to ask about, when we first learned about HPV and studied the virus, I'm talking about from a cancer biologist point of view, a lot of the interest was in E6 and E7 from
Yes.
the point of view of regulating signaling pathways that help the tumor cell grow. How is it the virus is, programming or reprogramming the immune system to avoid being detected once it's in its tumor cell integrated state?
I really don't know. I don't think anybody has had a good answer to that. It's possible that it just doesn't, that the proteins aren't reflected on the surface in the HLA. I don't think anybody has had a good handle on that.
I mean, does the virus somehow? I mean, there's other proteins there are other viral proteins besides E6 and E7. Are any of them still expressed in the tumors?
Yes, there are. E5 seems to have an important impact on aggressiveness. There's some evidence to that. E1 is eliminated during integration, and it looks like tumors that have more integrated virus are more resistant to treatment, so it may have some impact on viral persistence in the cells. But I don't think we really have a good understanding of this at all. There's a lot of virology to be done here, which hasn't been done. There are very few people that have been really in this field.
Yeah. I mean, we talked about this a while ago, and obviously it would be wonderful to recruit a virologist focused on this. And, it's not that, you're right, there are not that many people working in this area, but it's a shame given our really strong microbiology department. And also Peter Palese seems, very interested in this area as well. He seems to be enthusiastic. Two things. One, to get a good person is going to cost some money.
Yes.
But also, you can do, we could potentially, I just think it's just such a natural fit, for our, it's a common problem for us to be in this space. Does make sense. There's so much that's not known. Anyway, that's my.
Oh, thank you for that. I agree.
Marshall, this is Nina. Thanks so
Hi.
much. That was a absolutely wonderful summary. I had a couple of questions. One is, what is the vaccine the ID is trying to prepare? And secondly, can you comment on variants in E6 and E7, either for 16 or 18, that impact immunogenicity? and why 18 doesn't appear to be as immunogenic, perhaps?
Well, I don't know. I'm not the molecular virologist that we need to really investigate HPV. So I don't know what the molecular variations are in 16 or 18 that might make either of them more hidden to the immune system or suppressive of the immune system. What I do know is that HPV 16, all the HPVs do not elicit a dramatic immune response in the cervix when you have a cervical CIN. What you get is a low level of antibodies and very little in the way of T cells. You can't, if you get an oropharynx cancer with HPV, any type, we can measure antibodies to your early antigens years in advance. It's a good screening tool for early malignant transformation for anal and oropharynx cancer, not for cervical cancer. So integration is probably important in the biology of the cancer, and that's probably a tissue-specific effect as well as a cancer-specific effect. As far as immune masking and hiding, I don't know. I don't know what the virus has in its shell that might reduce its immunogenicity, or what it does inside the cell to make it less immunogenic as a foreign invader.
Yeah.
So those would be great areas to research, and we're really looking forward to being able to do that with you.
Yeah. And the ID group's vaccine platforms, do you know what that is?
Only from our HPV working group that they're working with Newcastle virus to try and develop a vaccine in that realm. I haven't heard anything new from them about what they've done. It'd be nice to get a progress report. But I think everybody has been redeployed at this point for the emergencies. So.
Right. But the good thing is, I think with vaccination, you can drive T cells into the tumor.
Yes.
And it'd be exciting to see with the HOOKIPA study whether that happens also.
Yeah, we did a study with the Advaxis project, which was a Listeria monocytogenes, a bacterial vector that was disabled. And that led to a cytokine release syndrome and a lot of significant toxicity. But we have long-term survivors. We have 3 patients still alive years after that study. So the vaccine may well have contributed to that. And it's very interesting that they're still going. And we may see the same here. They got other therapies afterwards, but it is a reason why overall survival remains good in this, is that patients do respond. And it's quite possible that some patients may actually be cured by chemotherapy alone, which I saw anecdotally in patients at Dana-Farber and here. So we have a few people that refused therapy, radiation, and were cured. So.
And sorry, one final question.
Sure.
When patients come in, have people done sort of a deep dive into baseline responses, just to HPV? I mean, my understanding is that you have to really do in vitro sensitization to find these responses, if they exist at all. The T cell responses, but I wonder how well that's been studied.
Well, I've only seen it in the context of clinical trials that are ongoing for the vaccines. For example, Andy Sikora did some of that for us with the TPF patients, and that was published. And then Charu Agarwal in the INO, forgive me for not remembering the number, for the INO study that she published last year in Clinical Cancer Research, they did some pre-vaccination T cell monitoring. I mean, we'd love to do that. Part of it is the logistics, and part of it is having somebody who's ready to do that. And I know you have someone in your lab who's interested in doing that. So we really love to get that done, both with the SIRS trial and with the quarterback trial patients.
Yeah, great, thank you.
Sure.
Go ahead, Michael. You're muted.
Complications in the prevention vaccine in teenagers or young women or young men?
Can you say that again? I didn't quite get all of it.
Has there been any morbidities or any big complications on the preventive vaccines given to teenagers and young adults?
The randomized trials show no impact of the vaccine on the on side effects. There's some muscular tenderness and some people get an occasional fever with it. But there were a lot of questions about whether people developed a post-vaccination paralysis syndrome, Guillain-Barré, which was shown to be equally likely in the non-vaccinated population as the vaccinated population. And then there were a lot of what I would consider group fainting spells associated with the vaccination itself. But there's really been no consistent findings that could be ascribed to the vaccine. It's extraordinarily safe. It is a shell of proteins. So from that point of view, it's unlikely to do anything, although that's possible. I'm more concerned about DNA and RNA vaccines, which have more hidden and unknown impacts. So it'd be interesting to see how that pans out.
Thank you.
Marshall, I have one maybe last question, and then I think we can wrap up. So the cell-free DNA
Yeah.
as a marker of like MRD, is it useful as a screening test? Can you actually, I mean, I know the prevalence is not going to be high, but in high-risk patients, does detecting HPV 16, 18 have any value as a screening test, or is it just so prevalent it wouldn't matter?
Well, there are two ways to detect. I think it's highly prevalent in the oral cavity. 3% of adult males will have it, and 1% of adult females will have it in their adult cavity at any one time if you do a random test. So the saliva is a test for risk, but it's not a good test. Everybody that has HPV-16 oropharynx cancer will have it in their saliva.
But that JCO paper was blood, right? Was that JCO paper?
The JCO chair paper is blood, so I'm going to come back to that.
Okay.
We did antibody studies, and we can show that you can develop antibodies up to 10 years before you actually have a visible cancer that's identified, and that the level of antibodies increases sequentially beginning about 2 to 3 years prior to the identification of the cancer. So antibodies are a very early detection marker for malignant transformation without necessarily having a target you can identify on scan or physical examination. These could be very small lesions that you're making an antibody response to. I think the cell-free DNA requires a certain level of tumor, which I think would be more visible or become more visible sooner in the patients than with the antibody test. With the antibody test, we want periodic screening on a regular basis. If you had cell-free DNA, I'd want to do a PET scan, an examination, and even get a rectal exam done, endoscopy, because those are the kinds of things that, but we don't have a one-to-one comparison of volume of tumor versus cell-free DNA. There are also some subtleties which I didn't get into, which are interesting. The cell-free DNA can detect integrated virus as opposed to episomal virus if you tweak it appropriately. And so it can distinguish between patients who have integrated versus cell-free. So it may be a prognostic marker as well in the screening facet. When you get the patient who has the disease, if they have more integrated virus, they may be more likely to require high-risk treatment. They can also distinguish the different subtypes, not just 16. And if they get a high integrated level, they may be able to identify cervical as opposed to oropharynx or anal. So there are some subtleties that larger studies will, I think, show us what's actually going on.
Great. Thanks, Marshall. That was great.
Glad to do it, and thank you. Great questions.
All right. Bye-bye, everybody.
So long.